Thank you very much, and good evening to one and all. Thank you to the organizer for giving me a very crazy topic, and luckily while searching for this, I was able to do a lot of lateral reading and probably clear a lot of doubts on those. I've got 7 minutes and I've got only 7 slides, so I'll not take too much of a time, and I'll try to cover like a relay racer for whatever is there. So this was a study which was done in Italy, and like we know, the Italians are very, very passionate regarding the PD L1 and the immunotherapy. So what they wanted to do is they wanted to find out a prognostic scoring system. And why they wanted to do that is because what they found was that almost 1/4 of their patients in lung cancer who were given monotherapy with pembrolizumab within a period of 12 weeks, that is within 3 months. Next slide, please. So it was a retrospective multi-centric trial which was involving 5 Italian centers, and their primary objective was to investigate the clinical features which were associated with fast progression. That is, individuals who progressed within the first 3 months or 12 weeks in PDL1 who were more than 50%, where we were very, very, very happy that the immunotherapy will work as first line in lung cancer. Next slide, please. So what is fast progression? Once again, anything that progresses within the first 12 weeks, the baseline clinical factors of the patients of these were analyzed and collected, and this was done in a very, very meticulous manner. They involved a lot of statistician in there, and they tried to devise a prognostic score. They studied a total of 321 patients out of the 336. These are the 321 who received first line monotherapy with pembrolizumab, because all of them had a PDL1 more than 50%. So what happened and what did they find? Next slide, please. So what they found out was that these are few factors which need to be understood. Amongst the 321, they found that 42.7% of the patients were fast progressors. And I do not agree with this data, probably because our Indian population do not progress that fast. But what they found was that the female sex, ECOG performance status 1 or 2, concomitant steroids, I don't know whether it was given because of the corona times, or I don't know why it was given, though it is a no-no, high tumor burden, and more than 2 metastatic sites, that is involving the liver, the brain. These were some of the areas where probably the fast progression was seen. So they used these high risk factors to make a prognostic score. Next slide, please. So they used this, and they made a scoring system ranging from 0 to 13, something like what we do in probably melanoma or lymphomas. And they found that 0 to 2 were the good prognosis, 3 to 6 was the intermediate prognosis, and then 7 to 13 were poor prognosis. But how did they score it? Next slide, please. So what they did was a 0 point was given for anybody who had an ECOG performance status of 0, male gender, less than 1 metastatic site, no corticosteroids, neither pleural or liver mets. These were given 0 points. Anybody having an ECOG performance status of 1 was given 1 point. 2 point was given for anybody with more than 2 metastatic sites, female gender, use of corticosteroids, pleural mets, liver mets were given 2 points, and anything PS of 2 was given 3 points. On this basis, they found that individuals with 0 to 2 score had a PFS around 15.6%, had a progression-free survival of less than 3 months. That is, they were fast progressors. Whereas a count of 3 to 6, 43.2%. So substantial tripling, almost tripling from the 0 to 2 happened. And individuals with 7 to 13 count had 76.8% progressed within the first 3 months. So probably a validated progression score for the fast progressors. Next slide, please. So what is the conclusion that they brought out? 6 clinical factors were independently associated with fast progression. They found a prognostic score model was developed to risk stratify the potentially improve the clinical practice and selection of first line PDL1 more than 50 in real world setting. So what does this mean in our practice? And I'll take just a minute for the take home message. Do we change our practice on the basis of this study? I feel no, because any individual with a PDL1 more than 50, we will definitely be tempted to give immunotherapy if the patient doesn't have any other driver mutation? Number two, would we be more vigilant, more careful of all these prognostic markers? Yes, we should. And I think we should definitely keep this in mind, that these individuals are likely to progress. So we need to not keep that on the back of our mind as a pseudo progression after probably three months of therapy, and probably keep these markers as probably a cautionary markers for these. Last but not the least, more studies probably on these are required. As of now, I think the immunotherapy probably are the drug of choice for such individuals. However, newer studies are required to make more robust prognostic scores. Probably Indian data is also required. Next slide, please. Thank you very much.
Thank you so much, sir. I would just like to ask, sir, probably in the high risk group, can we add chemotherapy to immunotherapy as well?
Absolutely. I think that is one point we should definitely take home from all this. Though I still re-emphasize that the prognostic panel which is there is not yet vetted or not yet probably standardized and requires still more. But yes, these are few factors where probably we can think of, especially when individual has an ECOG performance status of 0 and 1. Why not introduce chemotherapy in such individual and augment the effects of the immuno and chemo? So I think, yes, that's a very, very important take-home message.
Thank you so much, sir. Thank you for such a succinct talk, and it was really nice hearing from you.